Hello everybody, welcome to this Friday afternoon Parkinson's Academy webinar, the first one in a series in 2021. Obviously, so many of you have joined us, which we're very excited about, and it's obviously a topic that people really want to listen to. So I'd like to thank our sponsors, Profile Pharma, for sponsoring this webinar. So without any further ado, I'm going to hand over to Julie Jones to take off with this webinar. Julie.
Thank you, Daiga. So welcome everybody to this sunny Friday afternoon, and thank you very much for joining us. And also, as Daiga says, it's obviously a topic that interests many of you, just looking at the number of people who are logged on to this call today, which is fantastic. We're just going to take about 25 minutes to 30 minutes to run through the presentation, and then really Richard will be sharing some questions, and I think that will be interesting to hear what people's thoughts are at this time where we're all facing an ever-growing Parkinson's community who are affected by physical deconditioning. So really what I was asked to talk about this afternoon and what we're going to focus on is we're looking at exploring some of the factors which cause deconditioning, explore and discuss perhaps how we can identify deconditioning, particularly when we're in this environment where we're still remotely delivering interventions and consultations in the main. And then I think we're going to have some discussion about potential treatment opportunities and strategies to limit physical deconditioning within the Parkinson's community. So I suppose if we were to start physically, when we think about physical deconditioning, I think historically we've thought a lot of this within the Parkinson's community is solely attributed to the fact that people become sedentary, and the figures certainly would support that, and the fact that over 70% of people with Parkinson's are classed as sedentary. But equally of importance is the fact that physical activity seems to decline from diagnosis. So not only do they become very inactive, is that inactivity starts very young. And I think increasingly with us seeing people be more commonly diagnosed in their early 50s and in 40s, it really stresses the problem about people adopting physical activity habits right from the outset. Also, the evidence would suggest, and the quantitative data would suggest, that on average, people with Parkinson's only really take a mean step count of less than 5,000 steps, which is significantly below that is recommended. And particularly from this data, it would suggest that not only is that a small amount, but that intensity of that activity that participated is low intensity exercise. And when we're looking at maintaining our level of condition, we really need to be engaging in those sort of moderate to high intensities. So it's the small short bursts that are also problematic. Equally, we know that deconditioning and inactivity is associated with falls risk, and the number of people with Parkinson's who fall and indeed have recurrent falls is quite a significant proportion of the population. So what we have is really a sort of a recipe here where there's a huge amount of inactivity, which really starts off a vicious cycle. And then, as we're going to hear later on today, encompassed within that is the impact of COVID, and the Lancaster study, which was published at the end of last year, really demonstrated even amongst those people who with Parkinson's who were active, a significant proportion of them were reporting that they'd either stopped exercise or had significantly reduced their amount of activity. So we already had an inactivity problem that was causing and promoting physical deconditioning. But then I think the last 12 months of where we've found ourselves with the COVID pandemic has really exacerbated that even more. And I think on top of that, it's been at a time where many of us haven't been able to provide the services that we normally would have been to support people to maintain levels of physical activity. I suppose, as I mentioned, many of us, and historically it has seemed that it's only due to inactivity. But when we look at physical deconditioning, it's a difficult one. Is it solely a result of the symptoms of Parkinson's, or is it actually attributed to the consequences of Parkinson's? If we were to think about muscle weakness, there's a general consensus that people with Parkinson's compared to age-matched controls have considerable muscle weakness. But is that due to the fact that they start doing less, which therefore means that they suffer from muscle atrophy, or is it potentially part of the condition? And increasingly, there's a larger growing body of evidence that suggests that muscle weakness is actually one of the motor symptoms of Parkinson's. So there's an emerging evidence that suggests it's possibly a combination of both. And we can see that when we look at centrally mediated elements that could cause muscle weakness in Parkinson's. So we already know that the declining levels of dopamine within the basal ganglia have an inhibitive effect on the thalamus, which therefore has an impact on the motor cortex and reduces the amount of cortical stimulation, which therefore, thinking of that, it reduces the excitation within the muscles within the periphery. But equally, the variability in terms of the output of the basal ganglia via the corticospinal tract, that leads to impairment in the sort of activation and deactivation of muscle units as well, so on the motor unit. So from that perspective, we can also see that there's some centrally mediated pathways that are affected, which may impact muscle power. But equally, the small frequency oscillations that are generated within the basal ganglia also therefore impact and means that there's less stimulation of the high frequency motor units. And these are the ones that are required for the sort of holistic movements and the sort of powerful movements that are needed for stop-start, for changing direction and so forth. So when we look at that, therefore, is that people with Parkinson's, yes, there's these centrally mediated potential mechanisms, but these also then result in reduced muscle strength, that ability to generate force and speed. But there's also problems with impaired coordination and activation of motor units. And therefore you can see then, as that manifests in the periphery, the ability to have quick movement patterns and alter and move between movement patterns is the effect that we see. So potentially, therefore, we can see some evidence to support it's centrally mediated, but then equally with this existing in the long term, people start changing their behavior, their exercise behaviors or their activity behaviors, and therefore, if people have reduced muscle strength, it starts changing how they mobilize. So people start walking with shorter shuffling gait patterns, increased double support time, and as a result, that actually predisposes them to further muscle weakness. So for me, the two go hand in hand. If we're to look at the impact of bradykinesia and rigidity equally, so we're thinking of the broader definition of bradykinesia, it's not just a slowing of movement, it's also the loss of amplitude of movement. And many of us who see people in the early stages of Parkinson's are more likely to see that as in a loss of arm swing, which in itself may not seem to be overly problematic. However, when we think about how that affects the rest of the biomechanical tree, it really has some significant effects on an individual. So the loss of arm swing reduces, as the arm swings forwards, it reduces the rotational element within the trunk, which then reduces the lateral weight transference that happens at the hip, which then reduces the flexion moment at the hip joint, and therefore the step length is also reduced, and therefore it causes that shuffling gait pattern. So just that alteration of a loss of amplitude that happens there at the shoulder, what we get is a translation of problems going all the way down. As soon as we've got reduction in flexion at the hip, that actually therefore, that means we take a smaller step. And therefore the smaller step, it means the longer both of our feet are on the ground. Both of our feet on the ground means that we're not activating the glutes in quite the same way. We're also not testing our balance in quite the same way. And that then becomes a habitual pattern. So what we have, what starts off as a very simple musculoskeletal problem, it becomes a vicious cycle that translates all the way down. If we were to think about adding rigidity onto that as well, if you add the rigidity that happens in the trunk, that also affects that nice dynamic movement between the pelvis and the lateral weight shift, which then again affects their ability to balance and causes a lot of the postural dysfunction that we will see. So actually, at a very superficial level, and there's not enough time in this talk to go through the biomechanics, what we can actually really see is actually what may start as a centrally mediated problem, the symptoms that causes, then starts changing how people move, and therefore from that, it starts off a vicious cycle where the changes to their movement patterns will also predispose them to developing further restricted joint range of movement, reduction in muscle strength, also then have an impact on functional activity. So those three cardinal symptoms alone have a huge effect. I suppose, therefore, if we were to think of it from a broader perspective, is the factors which are affecting deconditioning in Parkinson's, and perhaps why many of you are here today, are multifactorial. And this is what makes it so difficult for us to be able to assess, treat, and manage. Because although I put all these different factors up here and one can consider them in ease for a talk in isolation, they're actually very, very interrelated. And therefore, trying to find an assessment tool that allow you to reliably and effectively assess each of these domains, while also considering the impact on functional ability, is very, very complicated. If we were to think about the non-motor symptoms of Parkinson's at the moment, depending on their particular Parkinson's profile, the apathy, the fatigue that people have, the loss of motivation, the problems with sleep, Therefore, trying to get people to be more active is particularly difficult, because that's very difficult for them to overcome those particular symptoms. If we also then think about, with Parkinson's being mostly diagnosed in the mid-60s, you've also got people who are deconditioning through the normal aging process. And we know from that, from the research in that particular area, the type 2 muscle fibers, the fast twitch muscle fibers start to deplete. As one gets older, we tend to have more arthritic changes in the joints, which also have an impact on movement biomechanics, on range of movement and so forth. So the natural aging process will also add into the already deleterious effects of Parkinson's in terms of physical conditioning. We've also got comorbidities, and unfortunately people never have Parkinson's in isolation. So thinking about cardiovascular issues, thinking about other long-term conditions such as cancer and arthritis, coexisting along the Parkinson's line will also influence deconditioning. And as I'm sure we're going to hear later on this afternoon, the impact of COVID on top of that. So multiple factors, and each of which has its own unique vicious cycle of inactivity coexisting together. And therefore, it really, really highlights at this stage is actually we have an increasing population of people with Parkinson's who we know were already physically deconditioning before COVID. It really stresses the importance of how we need to be addressing this to collectively, as a team of healthcare professionals, to slow the rate of decline. So as I've said, it's multifactorial. It's also, there's quite a lot of variation in the rate and pace and profile of physical deconditioning. And I think when we look at our patients, depending if they're young onset, later onset, that varies hugely. And I think that's something we need to consider when we're identifying in our assessments, what are the things that are key for that individual. And that therefore, when we're looking at the assessment, it has to be done on an individual basis. We need to recognise and address what are the barriers to activity for that particular individual. And we as a team of healthcare professionals need to be addressing those barriers within our service provision to limit those barriers, to help them support to be active and limit the impact of this vicious cycle of inactivity. We also need a flexible approach to management, and the fact that Parkinson's is a long-term condition, and while people may go through periods of accepting that condition, they also go through periods where they perhaps will fall off the exercise wagon or physical activity wagon, which happens to everybody with or without Parkinson's. And therefore services need to be able to recognise this and be able to pick people up and support them over the long term. And I guess the biggest thing, which will come as no surprise from a physio, is I think we need to be promoting physical activity from diagnosis. And that's not physios or exercise professionals pushing that. I think it's something collectively we as a healthcare community need to be stressing from the outset. So how do we identify physical deconditioning? And I think mainly from this, we need to be thinking of the challenges of using Near Me or using Zoom or using Microsoft Teams or whatever format we're using that at the moment. Observation is key. How long does it take them to get out of the chair? We know if it takes people more than 3 seconds to get out of a chair, that they're at higher risk of falls, and it's evidence or suggests that they've got lower limb muscle weakness. Do they need to use their arms to get out the chair? How many attempts does it take? When they're walking from the waiting room, or you see them walking in their house when you're online, what do they manage to have one foot on the floor at the same time, or do they have an increased double support time when both feet are on the floor at the same time? If both feet are on the floor at the same time in a shuffling gait pattern, you know they've got an element of balance dysfunction. You know, if they've got small step length and they're not getting hip extension or getting clear hip flexion, again, you know that there's potentially weakness or loss of range there. So a lot when we can do just by observing our patients. I'm equally a strong advocate of getting your patients involved in self-reporting, and I think with these short online appointments, I think that's something we could do, is start using patients and sending them self-administered questionnaires to prepare in advance. That also gets them to self-reflect on their own levels of physical activity and gets them involved in thinking about, as a key indicator of what they need to do more. So I've recently just issued some patients with some physical activity trackers, and a lady got back to me and was horrified that she realised she only does 800 steps a day. Now, she knew she was inactive, but actually giving her a number that realised how inactive, that ends up being something quite powerful that patients could do. So in terms of self-reporting, you know, things like the physical activity for older people, the pace measure, Things like using a self-efficacy scale for exercise could also be useful. The patient activation measure, all these tools are things that could be sent out to patients to complete and sent back, and then could be used to form the basis of consultation. And perhaps maybe that's what we need to be doing, is using our consultation time more effectively. And self-monitoring, as I've mentioned, things like a tracker, these are becoming more easily available. Some of them, they don't even need to wear a tracker, you know, having apps on their phone, and as long as their phone is in their pocket, that's something that they could do. Remembering that people with Parkinson's, one of the abilities to self-manage their exercise is one of the greatest unmet needs that people with Parkinson's have reported. Also, there's lots of evidence to suggest that people with Parkinson's want to be more involved in their own management, and perhaps therefore using self-reporting and self-monitoring, while it maybe has problems with reliability that some of you may feel is a problem, it does involve them in some of the decisions, and that's something perhaps that we need to embrace far more. And it means we can use our treatment time and our clinic time to think about solutions rather than gauging how big the problem is. So thinking about how we can measure physical, or how we can treat and manage physical deconditioning. The purpose of this talk really wasn't to talk about exercise per se in its widest sense, but exercise is associated with improvements in motor and non-motor symptoms, and there's quite a lot of literature being published to support that. But also, more importantly, exercise is perceived to be one of the most positive avenues at the moment towards disease modification. But interestingly, when we look at qualitative-based research encompassing what people with Parkinson's think, is they see it as the key avenue to rate the decline of Parkinson's. So what we seem to have is evidence that would suggest that people with Parkinson's are inactive, and we have evidence to suggest that people with Parkinson's want to be more active. So we can see, therefore, there's obviously a mismatch in the services that we're producing at the moment, where we've got an audience or a community who want to be more active. They need to be facilitated and enabled to become more active. One of the challenges to that, perhaps, is the fact that optimum dosage and means of delivery of exercise is undetermined. And I think exercise is very complicated to prescribe, and it's very much, to me, is akin to prescribing medication in the fact that it needs tinkered. We need to think about perhaps people that have a lot of postural hypertension. Perhaps, therefore, they're going to need short bursts of exercise due to that. Perhaps we've got young onset people who are working full time and are managing a family, and perhaps therefore the exercise needs to be something that can be done with the family, or something that can be done in a block of time after the day of work is done. So therefore it's difficult, therefore there's no recommendations of the optimal prescription for people, and the challenges that produces, therefore it makes it difficult for people to seek exercise and maintain exercise, because people want to make sure they're doing the right thing. I think one thing that we definitely know from the literature is that no one form of exercise is superior to another. The evidence doesn't support that any one approach is better than the other. But what the evidence certainly would point to, that an individualized approach to exercise is what is required. And I think from that, what we need to be mindful of the messages that goes to patients. And it needs to be combined with what they enjoy. So, you know, there's no point in prescribing an exercise program if people aren't going to enjoy it, because none of us are going to do it with or without Parkinson's. It needs to be individualized but tailored to their needs. A lot of patients enjoy Tai Chi, and there's an emerging evidence that would support the value of Tai Chi. Tai Chi is great, I suppose, for flexibility, for postural stability, but it's perhaps not necessarily going to address some of the strength issues. It's maybe not going to be beneficial for their gait. So we need to be mindful of what are their symptoms and making sure that the exercise program is tailored to that. So we need to think about the specificity of training. Dosage also needs to be important so that it's fitted in. And essentially what we need to do is be getting people to be physically active every day, but participating in structured exercise 5 times a week. And that's something, the message we possibly need to get across is physical activity is more akin to one having an active lifestyle, whereas exercise is something that's structured and tailored. And a lot of people could be referred to the exercise framework, which is available on the Parkinson's UK website, which would advocate that strength training needs to be done at least twice a week rather. We need to have balance training 2 to 3 times a day, and we need to be doing flexibility 3 to 4 times a week, and that gives them some sort of format. So really people need to be enabled with a sort of planner of their exercises that can be fitted in around their lifestyle. The other thing that perhaps maybe there is some evidence to support, but this is my professional opinion, I personally don't think that exercise can be prescribed in isolation. If you tell anybody that they should exercise, they'll nod their head and say, yes, I'll go and exercise. But it doesn't necessarily mean that they're going to do it. And so to me, exercise needs to be contextualized and it needs to be part of a package. People need to understand why they're exercising, for what purpose they're exercising, and for what benefit. Why are you making them do lunges? What is the benefit of lunges to their Parkinson's? What functional benefit can they expect to achieve from that? How soon are they going to see the benefits from that? And therefore, it has to be exercise, has to be delivered with contextualized education. But also what we really want is for people with long-term conditions to be able to manage to exercise and self-manage that exercise independently. And therefore from that, they also need the strategies to support behavioural change. So thinking of that, what strategies can we put in place that will enable people to be more active and limit this deconditioning that we see? And then finally, from us as a service provider, we need to be thinking about how we can support long-term participation in exercise. A lot of the research to date on exercise has looked at short-term benefits, but we need to be thinking in terms of our service design, how can we support long-term engagement? Because even the most motivated people who are active will be active for a period of time, and then we fall off the wagon, and we need to be able to pick those people up and have services that are responsive to that so we can bring them back onto the straight and narrow as it would be. So what do we need for managing physical deconditioning? We need an integrated approach, and a lot has been written on integrated care approaches, and that's making sure that people with Parkinson's can see the right people at the right time to manage their problems. And that's something that we need to be building into our service provision. We also need to be building in the formation of active partnerships with patients. Physical deconditioning is a physical problem, and therefore they're going to need to get physical to sort the problem. And therefore we need to be working in partnership with them, because this is something they have to do. It's not like giving somebody a medication, which is essentially something very passive that they just need to take. We need to be working in partnership for them to address this. We need to be empowering people to be actively involved in their management, and so thinking about contextualised and timely education. But they also need access to specialist exercise prescribers and access to specialist multidisciplinary team members. And certainly the evidence would suggest that if you're seen by a specialist healthcare practitioner, treatments are far more efficient, it's far more cost efficient, and actually patients have a better outcome as well. Strategies there need to be in place to support behavioural change. The one thing I always get is, I know I need to be more active, but what should I do? I'm aware I'm getting slower, but who do I need to see to help me? I'm aware my Parkinson's getting worse, but I don't know who to turn to. So services need to be there that are responsive, so we can think about signposting people there to the right time. And it seems sad that people are identifying that they have this problem, but at the moment, not all of our services can be that quick and responsive. And I think that's perhaps also going to be even worse at a time where, particularly where I am, north of the border, is a lot of community services have been stopped due to COVID, and therefore people who would ordinarily have been picked up perhaps haven't seen or had any contact with a healthcare professional now for over 12 months. So that in itself it makes the problem even more acute. And I think finally what we need is sustainable and accessible physical activity opportunities to limit the deconditioning that we're seeing in our patients. So I suppose they're really just to sort of finish up in terms of physical deconditioning. I think it's a combination of centrally mediated aspects and processes as part of the pathology, which then cause secondary complications, which then exacerbate inactivity. It's a multifactorial problem, but it is a multifactorial problem that has potential to be modified. And I think that is one of the key messages. It's a modifiable problem. We can deal with inactivity, and therefore we can limit the impact that physical deconditioning has, but it needs timely and coordinated services in order to be able to address that. And I think that's me. Thank you very much.
Julie, thank you very much indeed. I mean, ordinarily, of course, at this point, we'd pause for the thunderous applause that you would no doubt receive. But of course, in space and the internet, no one can hear you scream. So we'll just have to imagine that. So greetings all. I'm Richard Davenport. I'm about 3 hours south of Julie. I'm in Edinburgh. As you'll know, we're having something of a constitutional crisis up here in Scotland. I think we still just about have a government clinging on by its fingernails just at the moment, but that might change by the end of the day. Now, I'm just going to sort of just sum up a few things because Julie's covered that so comprehensively. What I'd like the audience to be thinking about doing is thinking about putting some questions in, because what we'd really like to get going is a discussion and your thoughts about this. But just as a way of a preamble, some thoughts of mine, which is really just enlarging what Julie's been talking about. I think the first thing to say is that although it's the pandemic that in many ways has triggered this debate, I think we should be hopefully looking forward to the sort of post-pandemic era, hopefully later this year, and using this as a trigger to rethink about how we do that. So I don't want to sort of this to be dominated by where we are now in many ways. So thinking about purely the pandemic era. Just before we leave that, however, just on a brief positive note, whilst there's no question that many people have suffered, not just people with Parkinson's, but many neurological conditions, certainly in PD, there's a small group who seem to have positively benefited, and they tend to be the younger people. And I can immediately think of at least 3 ladies, and they were all ladies, interestingly enough, who are absolutely delighted that their local golf courses have been closed for several months because it enabled them access to the golf courses for walking. And I think, you know, there is a small group of people where they've really embraced the period of lockdown and actually done far more exercise than they might otherwise have done. Unfortunately, they are a small group, but it is worth just recognizing that. There's a much bigger group, unfortunately, who have suffered. And I think that, without sounding too pessimistic, I think in many ways some of that group are not going to regain what they've lost. And that's why I want to sort of think a little bit more about the future as much as anything else. And thinking about sort of service reconfiguration and what we might be thinking about changing. Julie's touched on all of these, but one of the things that came across thought to me was the issue of education. And that has to start right at the beginning. And when I say education, I don't just mean of patients and their families. I think actually healthcare practitioners, and I think particularly doctors. And I can say this because I'm a doctor. But I think that actually we're brought up with a very medical model, and we spend all our time thinking about, shall we tweak this? Shall we introduce an agonist? Shall we do this, that, the other? When's the next new sexy drug coming along? And actually, this is nothing to do with drugs or drug therapy. And it makes the point there's an awful lot more to living with Parkinson's than just our 6 or 12 monthly review and a fiddle about with the drugs. And I think we need to take that on board, and I think we need to be teaching our trainees this, and we need to be embracing all the evidence that Julie was referring to, that increasingly these things might actually be disease modifying, which they're often not. I've got a comment here saying someone can't hear me. Can most people hear me okay? Okay, all right, okay, good. So the other thing that Julie made the point about was individualizing treatments, and that's of course entirely true. And there was that slide when you talked about the influencing factors in deconditioning, and of course you could use many of those to thinking about individualizing treatment programs. So age, existence of non-motor symptoms, personal beliefs, I think is hugely important, and that comes back to education. And are you the kind of person who enjoys exercise? If so, do you enjoy it in groups or just in isolation? So all those kind of things to be taken into consideration. Comorbidities, of course, and whether you have a job or not. We should all be exercising. And I can't be the only person sitting through Julie's program thinking, yeah, I'm really not exercising as much as I used to for all sorts of reasons. I tend to sit at home much more than I used to, and it's difficult to get out and all those usual excuses. And of course, also recognizing that as an organization, the NHS is not that well predisposed to individual programs. We're a big machine, and that's how we sometimes seem to both employees and patients, and how we get through to that. But I think that we do need to be thinking about embracing technology. Julie touched on those as well, and we need to get smart about thinking what are the smart things and smart meters that are actually useful, as opposed to the fluff around the edges. Of course, we need to be evidence-based, but actually I think some of the evidence base is already there, as Julie's touched upon, and really what we're talking about is how we monitor that exercise. And I think the point that you made about pointing out to somebody they're only walking 800 steps is very powerful, because that really brings it home to you. It's a metric that makes sense to people. You know fully well that 10,000 steps is that slightly mythical figure that we all should aim for, but the point is 800 is a long way short of 10,000. So whether 10,000 is right or not doesn't matter. Under 1,000 sounds not very many, and I think that really helps patients to conceptualize it in a way that they may not have been able to do. And also the practical advice, and I'm often asked in clinic, so, well, what sort of exercise should I be doing? What do I go and buy a static bike? What should I do? And I think again you touched on that, Julie, and some of the ideas. So that's just really a sort of brief kind of summary. But we're getting some questions in here already, which is absolutely fantastic. So we've got a first one here for yourself, Julie. So there's a question here about medication management is passive and exercise can really empower people. Exactly. So just exactly what we were saying. Do you find that some patients with Parkinson's can be very apathetic towards exercise? And what about the effect of depression and mood? And how do you deal with that? So comments on that, Julie.
Thanks for your question, Deborah. Absolutely. I think there's a huge amount of apathy. But one of the big problems I have is there's so much information available to people with Parkinson's now. If they go online, there's so much information about exercise, and it's actually very difficult for them to navigate what is best for them to do. And so one of the things I think that they really appreciate from exercise professionals is some sort of clarity. And I know we're in an era where it's about patient choice and patient-centered care, but actually they're coming, they want guidance. They want guidance about what is the right type of exercise for them to do at this moment in time. So I think some sort of succinct clarity on what is best for them and why is a good place to start. The other thing that I know has been difficult during COVID and the restrictions is finding an exercise buddy for them. And I think this is something that a lot of people would benefit if they can find somebody else that they were exercising. We're very British. We decide not to go out for a walk by ourselves, but if we've made an agreement with somebody that will meet them at 3 o'clock for a walk, we will meet them for a walk at 3 o'clock. And so I think exercise buddying is good. And actually, interestingly, a few people have started buddying up using some of the videos that people posted on the YouTube, and people are choosing to do that at the same time. So buddying up online is something that they can do, and they can watch each other while engaging in exercise. So that would be the other thing. The other thing I would suggest is start with some small goals that are achievable and keep the exercises simple. I think if the exercises are too complicated, too difficult to fit in, then people will give up. So start with something you actually think they can do, and that gives you that positive win to start with, and then you can build it up. The other thing that I think is quite clear to do is myth bust. I find a lot of people blame everything on their Parkinson's. And I think we also need to be realistic on, I'm really tired today, it's awful, but maybe sometimes I think, well, what did you do yesterday and what did you do the day before? And actually thinking for many of us, if we went out for an 8-kilometer walk one day and then, we had the grandchildren to look after for another day, you'd be exhausted by Wednesday, whether you had Parkinson's or not. So it's also trying to just put in a little bit of realism amongst that as well, I think is useful, Deborah, for dealing with the apathy. But goal planning, buddies, and starting gently.
Yeah, I endorse all of those. Just coming back to buddies, you had a cartoon, and I'm going to express one of my biases here. A sort of exercise dog, and I have to say, I not uncommonly suggest to people they think about getting a dog, because that's the other thing that will get you out of the house. The only thing I would say to that is if you do get a dog, don't get a greyhound. I have 2 greyhounds, and contrary to popular belief, they are the laziest animals on earth. They will walk for about 10 minutes and then they will give out. I mean, they're designed to run very, very fast for about 28 seconds. And that's all they do. And once they're retired, they're retired. But joking aside, you're absolutely right, sort of exercise dog. Now we're getting loads of questions in. I know I'm not going to be able to deal with all of them, but I'm going to pick out some of my personal favourites. One of the things here is Sarah McCracken, PD nurse specialist, doing some research into Nordic walking, and of course that's one of the topics that does come up, and I think that's been the subject of a seminar as well. Do any of the physios have experience of Nordic walking and wearable trackers? So Julie, where do you lie on the enthusiasm for Nordic walking?
I'm a fan. That's my short answer. I suppose my longer answer for that is I think Nordic walking has a number of advantages. One, they're walking with poles, so people who are starting to feel slightly insecure about going outside, and you mentioned about that confidence. I think sometimes walking with a pole is what gives them the confidence to walk further. They don't look like a walking stick, so it takes away a lot of the connotations, negative connotations associated with a walking stick. I prefer them to walking sticks if their balance allows, because you hold them like this and therefore it encourages trunk rotation, whereas a walking stick encourages flexion and leaning forwards and putting weight on the stick. So from a biomechanical point of view, they improve the sort of stability and the patterning of walking. So I'm a big fan of that. And there's also a number of Nordic walking groups. So for those that don't like a Parkinson's named groups, throughout the length and breadth of UK, there is Nordic walking groups. So it's something that's quite easy for them to enjoy a club or a group. And particularly at the moment when we're outside mobility is allowed or outside exercise is allowed, it's a great form. I think we just need to be mindful of who we prescribe it to, because actually getting the arms and legs coordinated can be a little bit difficult for people to get started with. But once they're off, it is a great approach. Was there a second part to your question?
Yes, it was, and there was one of your slides was all about, which ended up with shortened stride length. That slide when you took us through, and that was the one that triggered me to think about Nordic walking, because that seemed to be all about that kind of idea. I guess it comes back. It comes back to this idea that in many ways it almost may not matter that much what you do, just do something, and as you say, don't try and persuade people to do Nordic walking if the whole idea of them going around with poles just turns them off. Maybe they're the dog person. Ditto the person who can't stand dogs, maybe they're the Nordic walking person. It's finding something, because nobody will ever do exercise or any kind of, if it's not, to at least to some extent, enjoyable. And I think you made that point.
Absolutely. And I think if you get them started with walking poles, and then once they get confident and they build up that sort of, confidence with exercise, you can do a whole lot of things with poles. You can hold them and you can lift them above your head. You can work on rotation. So you can then build in a sort of exercise program around the poles as well. So that, and I think maybe that goes back to the question earlier about the apathy. Start them off small, get them confident, bring them in, and then start increasing the ante of what you're expecting them to do.
Okay, and ideal for measuring your 2 meter exclusion distance as well. Now, Jen Piggott's come a very quick question, which I think I might take. So Jen making the point, many people report motor fluctuations in their symptoms as an obstacle to exercise. Any tips for them? So Jen, yes, I think that's a good point. And I think that's part of maybe optimizing their medication, of course, in one way, although I've stressed that that's not what it's all about. But I think also it's looking at what's the suitable time for them doing exercise. We all recognize that many people, particularly as their disease advances, will typically say, I dip in the early afternoon, or I'm not so good in the morning, or whatever it happens to be. Sometimes it's unpredictable, but often people are fairly predictable about that. And I think it's a bit of discipline there, and trying to encourage them to sort of use their good time for exercise if they can. I know that might seem a rather obvious answer, but a lot of these things are relatively obvious, and as healthcare professionals, we're there to just try and reinforce them. So that's the tip about fluctuations. Now there was another question that maybe, yeah. So Nadia Mathers had asked about. Can you, and Julie, I hope this you will be you rather than me, can you, Julie, explain a bit more about the outcome measures you mentioned? Brackets, pace, close brackets.
Hi, Nadia. I mentioned the PACE, which is a physical activity scale for the elderly. And there's another one that is, so that's the PACE, PASE, and then there's the PASID for individuals with disability. I have to say, I'm not keen on the title, but they are measures that you can use. They go through the last 7 days. It looks at measuring strenuous activity, moderate activity, and low activity. There's obviously the iPack that you can use as well. The only problem with the iPack is it's validated for people up to the age of 65. So depending on your client group, that may or may not be beneficial. And the self-efficacy for exercise scale. So that also gives you an idea about how confident they feel about exercising. And so when we're thinking about a sort of behavioural change model, like thinking about pre-contemplation, where are they on that scale? The self-efficacy scale can be good for them to use. So and the other one that does require a license, but I know in NHS England have a license, but it's the patient activation measure, PAM. That also is another good one to see where people feel they're at about ready to take on exercise. And then it's nice to reevaluate that at the end of your intervention. Where do they seem? So it's useful for those sort of patient-sided outcome measures. Nice to hear from you, Nadia.
Thanks, Judy. And I'm going to take one more quick question, which I'll try and answer. So there's a question here from Susantha Wijayasira saying that she gets many referrals referred as an inpatient with Parkinson's disease in the COVID period, and that seems to be more than used to, and felt that has triggered their deconditioning due to the obvious reasons. Is this the experience of many? Yes, Susantha, I think absolutely. Yes, exactly right. I mean, deleterious effect, and that has led to more admissions probably. So I agree with that bit of your question. The second bit, you said, should we offer amantadine as a bridge to improve their PD control as added benefit? I feel that maybe this should be the case, but I've not tried. Well, I'm going to slightly disagree with that bit, Susantha. I think the experience of many of us is that amantadine as a PD treatment is not terribly effective and does have a number of adverse effects. I think the place where most of us use it with modest success is as an anti-dyskinetic agent. I think it's a drug to be wary of. I think the point is that I think that drug treatment in these situations is often surprisingly disappointing, which reflects the fact that there's a lot more going on here with deconditioning that's not dopamine responsive. So that's been my experience. I've been a bit parsimonious with change. I've been trying not to change drugs too much if I can, and when I have done, it hasn't been terribly successful. So I think that comes back to really the sort of central theme of today's talk, which is this is less about drugs and medicine and more about sort of physical treatments and physical approaches. And that comes right back to where we started, which is education from day one. So day one, when we make the diagnosis, we all need to be hammering home the importance that this is not just about drugs, this is about lifestyle, and a huge part of that lifestyle is exercise and maintaining exercise with the confidence that it might actually be the only thing so far that actually is disease modifying, which is so you can do it with the confidence that there is an evidence base behind that. And whether that involves them buying some Nordic poles, or whether that involves a new furry friend, or whether that involves, whatever it happens to be, I don't think it matters too much, but just emphasizing the importance of that. Well, look, just bang on time. I'm going to bring this to a close. So, Julie, thank you for doing all the hard legwork. You've carried this. I hope the audience have enjoyed it. I'm pleased to see the numbers have gone up while I've been talking rather than going down, which is always a positive. So that's fantastic news. Thanks to the PD Academy for sponsoring this.